Howdy. In today's video, we're diving into an innovative approach to treating non-steroidal anti-inflammatory drugs toxicity, also known as NSAID toxicity, in small animals using manual carbon hemoperfusion that does not require expensive equipment. This technique was recently described by our colleagues from the University of Florida. When a patient presents with a massive NSAID overdose, treatment options typically include conservative management with early decontamination, IV fluids, gastroprotectants, antiemetics, and sometimes even lipid emulsion. Or more aggressive definitive treatment like extracorporeal blood purification can be considered as well. This allows veterinarians to remove a large portion of the toxin from circulation within a very short period of time before clinical signs develop. Extracorporeal blood purification has become increasingly popular for treating NSAID toxicity in dogs and cats. When it comes to NSAID overdose, extracorporeal therapy can be performed using one of the two primary methods. First, it is therapeutic plasma exchange, or TPE. This process involves withdrawing blood into the extracorporeal circuit, separating a pre-specified amount of plasma from red cells, using a membrane-based plasma filter, and returning the red cells and remaining plasma back to the patient. The most commonly used membrane-based TPE machines in veterinary medicine include Prismax, Prismaflex, both manufactured by Baxter. Alternatively, TPE can be performed using a centrifugal plasma exchange, which spins down blood to separate plasma and red cells instead of using a membrane filter. The second extracorporeal method is hemoperfusion. In this process, blood is passed through a sorbent, such as charcoal, carbon, to remove toxins via adsorption. The hemoperfusion machines most commonly used in veterinary medicine include those from the manufacturers shown on the screen. But here's the challenge with standard machine-based TPE and hemoperfusion techniques. Most of these require a large extracorporeal circuit volumes, which can lead to cardiovascular instability, especially in smaller patients. For example, the smallest priming volume for a TPE circuit on the Prismax or Prismaflex machines is 125 mils. In dogs and cats under 8 to 10 kilograms, this volume could cause a state of hemorrhagic shock unless blood prime is performed. But blood priming is not always straightforward. It requires specialized training and increases procedural risks. Last but not least, TPE and hemoperfusion machines are expensive and require specialized personnel, making them inaccessible in many clinics, even in countries with advanced veterinary medicine. So, what is the alternative for treating NSAID toxicity? The good news is both TPE and hemoperfusion can be performed manually, meaning no expensive equipment is needed. Manual TPE has been well described in multiple veterinary case reports. The process involves placing a central line, withdrawing 10 to 15 mils per kg of blood, and placing it into a blood bag with anticoagulant. The blood bag is centrifuged to separate plasma from red cells. The plasma is discarded since it contains the highly protein-bound toxin, while the red cells are returned to the patient. This process is repeated multiple times until 1 to 1.5 plasma volumes are exchanged, reducing plasma toxin concentration by about 50 to 75%. But there's a major limitation. Manual TPE is extremely labor-intensive and time-consuming, often requiring hours of work from multiple staff members. This brings us to today's main topic, manual carbon hemoperfusion, or MCHP. Manual hemoperfusion had not been well described in vet literature until recently, when the awesome team at the University of Florida published their case series. It offers a low-cost, time-efficient alternative using a standard triple-lumen central line, a small-bore circuit, and a carbon hemoperfusion column, which can be easily purchased online. Manual hemoperfusion is a straightforward, practical method for rapidly clearing highly protein-bound toxins like NSAIDs from circulation of smaller patients without requiring expensive hemoperfusion machines. Now, let's walk through two real-life cases that were recently described in the literature. In both cases, manual hemoperfusion was utilized instead of traditional extracorporeal therapies or manual TPE. An 11-month-old, 3.5-kilo domestic short-haired cat was hospitalized for wound management. 24 hours later, a dosing error resulted in an overdose of meloxicam that was given at 0.48 milligram per kilogram. Despite immediate gastroprotectants, including famotidine and sucralfate, extracorporeal treatment was considered due to the high dose and patient's comorbidities. Since the cat was too small for traditional TPE or hemoperfusion, the team opted for manual carbon hemoperfusion. A standard triple-lumen jugular catheter was placed, and a small volume circuit was created using a carbon hemoperfusion column. The circuit setup is depicted on the screen. It included 53 centimeter extension set, male-male adapter, Christmas tree adapter, cut portion of the hemodialysis circuit, and the sorbent, which was the hemoperfusion column. A 12 ml syringe was connected to the stopcock to manually remove blood from the central line, push it through the hemoperfusion column, and return the blood by peripheral IV catheter to minimize access or circulation. The extracorporeal volume was just around 50 mils, avoiding the need for a blood prime. Over 60 minutes, 5.5 blood volumes were processed, with continuous monitoring of electrolytes, glucose, PCV, and clotting times. The cat tolerated the procedure well, and plasma meloxicam levels dropped by 44.4%. The cat remained hospitalized for wound management, showed no adverse effects, and was discharged 12 days later. The case 2 involved suspected ibuprofen ingestion in a dog. A 1-year-old, 2.6 kilo mixed breed was suspected of ingesting up to 3,700 mg per kg of ibuprofen. Despite decontamination measures, including apomorphine and activated charcoal, the potential for severe NSAID toxicity remained. Since machine-based TPE or hemoperfusion was ruled out due to the dog's small size, manual carbon hemoperfusion was chosen instead. A triple-lumen jugular catheter was placed. A carbon hemoperfusion column was used in a low-volume circuit, similar to the cat's treatment. In contrast to the previous case, the setup was simplified using extension sets only, avoiding cut hemodialysis circuits for better security. Over 90 minutes, an estimated 18 blood volumes were processed. The dog remained sedated, but some transient complications have occurred and included mild hypotension, hypothermia, and regurgitation, likely attributed to ionized hypocalcemia, which was corrected with IV calcium gluconate. At 24-hour follow-up, she was reported to be doing well, with no adverse effects from the treatment. Before and immediately after the manual hemoperfusion treatment, plasma samples were obtained similarly to case 1 and submitted for ibuprofen quantification. Both samples were below the limits of detection, meaning that this dog was unlikely to be exposed to ibuprofen at all, or early decontamination was very effective. However, it was important to describe this case due to the important circuit setup modification that was different from the feline case. So, what are the takeaways? First, manual carbon hemoperfusion offers a practical, low-cost alternative to traditional extracorporeal methods for treating NSAID toxicity in small dogs and cats weighing less than 5 to 8 kilograms. It allows for rapid toxin removal within 60 to 90 minutes. And the main benefit of this setup is that it uses a low extracorporeal volume circuit, only 40 to 50 mils, which is critical for minimizing cardiovascular instability in small patients. While manual carbon hemoperfusion presents promising alternative for treating NSAID toxicity in small animals, there are important limitations to consider when using this method. One key limitation is the lack of precise control over blood flow rate. Unlike machine-based extracorporeal treatments, manual hemoperfusion relies on manual blood withdrawal and reinfusion, which introduces variability in flow rate. Fluctuations in blood flow could impact the efficiency of toxin removal and increase the risk of complications, such as clot formation within the circuit. Another challenge is the absence of built-in safety sensors and alarms to detect potentially fatal complications, such as clotting in the circuit or air embolism formation. Sterility is another concern. In case 1, the circuit was assembled by cutting hemodialysis lines to create a closed-loop system. However, these connections were not designed to be locking, which posed a potential risk for dislodgement, significant blood loss, and loss of sterility during the procedure. Ultimately, prospective studies are needed to prove that this method is safe. All right, that's it for today's video. If you found this case discussion helpful, let me know in the comments below. And before you go, I need your help choosing the next topic we cover in this channel. Drop a comment below with what you'd like to see next. Thanks for watching, and I'll see you next time. Bye for now.